Hello, good afternoon everybody. I invite all the co-chairperson, convener, moderator to the dais please. And good afternoon. Without delaying further, we start this session. And our first presentation is Mr. Lakshay Yadav, masquerading in plain sight, pigmented corneal ulcer mimicking corneal body. Yeah.
So, good afternoon everyone. Today I am going to present on a topic masquerading in plain sight pigmented corneal ulcer mimicking foreign body. A 55-year-old male presented with complaint of left eye pain, watering and redness and diminution of vision for past 1 week, which was sudden onset, gradually progressive. There was no history of ocular trauma or surgery as reported by the patient. Patient is a known case of type 2 diabetes mellitus from past 5 years. There was a history of left-sided 7th nerve palsy 2 months back, for which he didn't took any treatment. There was no history of headache, nausea, vomiting or seizures. Patient took a local consultation for ocular symptoms and was diagnosed as left eye perforated corneal ulcer with iris prolapse and was referred to higher center. On ocular examination, BCA was 612 in right eye. It was hand movement close to face with PR accurate in left eye. D10 was within normal limit in both the eyes. Anterior segment was within normal limit in right eye, and corneal sensations were reduced in both the eyes. On examination, there was a lag of around 5 mm was noted, along with upper lid and lower lid edema. On slit lamp biomicroscopy, a central elevated pigmented lesion with an epithelial defect of almost around 3 into 3 mm, and the ulcer was dry looking with feathery margins, and a 1.5 mm hypopyon was noted. After making the slit, AC was well formed, iris was round and in position, so there was no perforation at all. Lens was NS nucleus corrosive grade 1 in right eye. It could not be assessed in left eye. Posterior segment of right eye showed mild NPDR, and left eye the glow was faint, so we underwent an B scan which showed anechoic vitreous cavity with retina on. So we made a provisional diagnosis of left eye infective keratitis. It was likely to be fungal with a central pigmented lesion with 7th nerve palsy and diabetes mellitus. What next? Then we decided to scrape off the lesion and send it for corneal scrapings. And to our surprise, the entire pigmented lesion was removed in toto, and KOH mount was showed pigmented hyphae along with conidia, which was lunate, brown colored with septate. And the culture showed curvularia lunata. We underwent all the systemic tests of the patient, but they were absolutely within normal limit. So final diagnosis, we made it of left eye fungal keratitis due to curvularia lunata with 7th nerve palsy and diabetes mellitus. We started the patient on eye drop netamycin 5% hourly along with voriconazole 1% hourly, and we also advised the patient to tape the lid at night because there was a lag of around 5 mm. On follow-up, the hypopyon was resolved, ulcer started to heal with pigmentation. Unfortunately, patient was lost to follow-up. That's the picture after 2 weeks, and after that we couldn't trace the patient. So we reviewed the literature and we found a case series on curvularia keratitis, and it showed that the incidence of fungal keratitis is almost around 10.3 per 10,000 of population, and out of fungal keratitis curvularia is around 3.7, and out of that our patient presented with a pigmentation which is around 25% of all the curvularia cases. So it's some kind of rare condition. So yes, learning points from this case: basically edematous fungi can rarely present with an elevated pigmented lesion which can be mistaken for prolapsed iris. Detailed ocular examination is important to arrive at correct diagnosis. Corneal debridement in fungal keratitis helps in reducing the organism load and improve drug penetration. As diabetes and 7th nerve palsy were 2 important risk factors in our patients, systemic management should be done simultaneously. Thank you.
Yeah, thank you, Dr. Lakshay, for excellent presentation and giving us an idea about the risk factors also, diabetes. And I would like to ask that what you did for that after healing of the ulcer. Did we do anything for the 7th nerve palsy?
Sir, actually, we were planning because we were feeling that the patient is a non-compliant one because he was having ulcer from past 1 month and he didn't took any treatment. So in the beginning, we gave him lid patching only because we are not sure if he'll do lateral tarsorrhaphy, whether he'll put the drops or not. So we advise the patient to continue the treatment and come after healing. Then we'll do the lateral tarsorrhaphy or something like that. But the patient was lost to follow.
Okay. So we need to take care of the risk factors.
Yes,
And thank you so much for
Thank you, sir.
presentation. Now we move on to the next presentation by Dr. Shilpa Das, bilateral contact lens induced severe keratitis. Where to draw a line? Dr. Shilpa Das, please.
Good afternoon everyone, I am Dr. Shilpa and today I present to you an interesting case of contact lens induced severe keratitis. Now a 26-year-old female presented with whitish discoloration and defective vision in both eyes since 2 weeks. She was a myopic and she was a regular contact lens user. She was already treated before presenting to us with topical antibiotics, fortified vancomycin and ceftazidime for 5-day duration with no response. Now this was the day 1 presentation where she had bilateral 9 into 9 millimeters grayish white infiltrates with rounded smooth margins, anterior to posterior distribution with the intact epithelium and fine granularity. At this stage, the corneal scraping was done, and while the reports were awaited, we looked at differential diagnosis of corneal ring infiltrates, which include neurotropic corneal ulcer, acanthamoeba keratitis. Sometimes it can be pseudomonas or fungal keratitis, peripheral ulcerative keratitis or subgent keratitis. In our case, our clinical suspicion was first to be acanthamoeba keratitis, especially since it was contact lens related. The treatment was shifted to polyhexamethylene biguanide eye drops while also adding voriconazole and ceftazidime to cover for fungus and bacteria as the micro reports were awaited. This you can see day 4 picture. Within 3 days, there was a drastic reduction in density and size of the infiltrate. However, microbiology came negative. We also did a confocal scan which came negative for any organism. This made us wonder because such a quick reaction for acanthamoeba keratitis with PHMB eye drops in just 3 days is not possible, and there was an intact epithelium with minimal pain. Hence we thought whether it could be immune keratitis. Weasley rings or corneal immune rings are sterile, non-infectious ring-shaped stromal infiltrates that can occur due to a hypersensitivity reaction, most common being foreign bodies, contact lens wear, refractive procedures, etc. And interaction of these foreign antigens with antibodies from limbal vasculature result in immune complexes which activate the complement system. A low density of antigen presenting cells in the central cornea and a 5:1 peripheral to central ratio allows these rings to be more peripheral and the central cornea gets spared, and these antigen antibody complexes they deposit peripherally. This is a similar presentation of a Weasley ring in a patient with contact lens history, who developed a immune keratitis. Hence, we changed our treatment regimen based on this with the introduction of topical steroids, that is prednisolone acetate eye drops was introduced initially 4 times a day with a background of reducing ceftazidime, vozole and PHMB. This is the day 7 picture where just 3 days later we saw further reduction in density and size of the infiltrate. Now since we were sure, we completely stopped the antibiotics and shifted to prednisolone 2 hourly along with addition of tablet Vizolone 20 mg, which led to reduction in stromal edema and further clarity of the cornea. And you can see in just 8 weeks, the best corrected visual acuity improved to 6/9 in both eyes. And here we tapered the steroids in order to achieve complete clarity. Hence the case was rested. To conclude any case of severe keratitis, looking at the clinical picture, we suspect infection first, do your microbiology and the confocal and other diagnostics available to rule out infection, proper documentation and aggressive management, reassess the situation, look for the response and change approach whenever necessary to get the eventual cure. Thank you very much.
Thank you, Dr. Shilpa, for excellent presentation and excellent case. I would like
Thank
to
you,
know one thing. Did we culture the contact lens solution used by the patient or the contact lens itself?
Unfortunately, no, sir, because that was removed by the primary ophthalmologist. So before sending to us, they had discarded the contact lens and the solution. So, but yes, that would be the right way to culture that too.
One thing is there that because it was a bilateral presentation, very smear and then infiltrates also, I would like to ask you that you have to go for the treatment as an infective only.
Yes,
even
sir.
if even if we suspect it, which is
Yes,
and your case
correct.
also in the beginning
Correct.
has responded to the
Yes.
treatment, which is a
Yes.
cocktail treatment, but it has
Yes.
responded.
Yes.
And to me, basically, bacterial keratitis remains the most frequent
Yes.
one, and that will be taken care of the antibiotic. And
Correct.
in any other case, we do
Correct.
go for the topical steroid.
Yes,
later on.
yes, sir.
What do you plan for the future for this patient? What is your suggestion?
This patient vision is almost near normal now, 6-8 parts in the other eye. So once we stop gradually taper the steroids, we just continue the topical lubricants. And then now she is afraid and not keen to go back
Yeah.
for contact lenses.
That's
so
what I wanted
just
to-
glasses for now.
Okay. Thank you so
sir.
much.
Thank you.
We move on to the next presentation by Dr. Maria Doctor, microbial keratitis in ichthyosis, diagnosis, challenges and management. Dr. Maria, please.
Thank you, sir. Thank you for giving me this opportunity to present today. So, I'll be presenting a case of microbial keratitis in ichthyosis, diagnostic challenges and management. Main objective of this presentation would be to know about the various associated ocular manifestations in patients with ichthyosis, to explain the factors predisposing these patients to microbial keratitis, and to devise a comprehensive management plan for ocular manifestations in these patients. So, ichthyosis is actually an inherited group of disorder affected most of the integument. It is characterized by skin thickening, xerosis, that is dryness, and scale formation. It occurs due to defect in cell adhesion and desquamation, which leads to stratum corneum disruption and transepithelial water loss. Ocular affection involves mainly the eyelid, the meibomian gland, conjunctiva and the cornea mainly. So coming to our case, this is a patient, 30-year-old male, having short stature. On external examination showed generalized coats, large brownish dark scaling all over the body, eclabium, which is outward protrusion of the lids, along with digital constriction and palmar keratoderma. He presented with complaints of decreased vision in the left eye since the past few days. In the right eye, he had visual loss since the past few years post an episode of microbial keratitis. His visual acuity in the right eye was PLPR accurate, while that in the left eye was counting fingers. On examination, as we can see, he had total ectropion, atrophic meibomian glands. On the right eye, we see the cornea. There is a central leukomatous corneal opacity with an underlying adherent leukoma formation, while in the left eye, there was thickened congested conjunctiva and the cornea showed a corneal infiltrate. Since this patient was now difficult to examine on the slit lamp to know the exact size and dimensions of the infiltrate, neither was it possible for us to take a scraping. It was planned to do it in the OR. In the operation setting, we noticed that the patient had a geographic ulcer and even the lesion appeared to have dendritic edges. Hence, we went ahead and did the corneal scraping for gram and KOH, and also a RT-PCR for HSV was done. So, as of now, we had a provisional diagnosis of HSV stromal keratitis with ulceration, and the patient was started on topical Asavir eye ointment along with an antibiotic and lubricants. However, within next 3 days, the patient worsened, and by this time, we had the IFA PCR report, which came out to be HSV positive. So, we now started the patient on tablet Asavir along with CMC, and within a week's time we could see that the ulcer edges had showed consolidation and also vascularization had started, and this is when we added steroids. This patient gradually improved. However, the course was extremely prolonged and it took around 3 months for complete visual recovery. So, the various ocular tissue involvement, as already mentioned, include eyelids, meibomian glands, cornea, and infrequently the lens and the retina. And mainly it involves the eyelid and the meibomian glands because of the dryness of the skin and also the atrophic of the meibomian gland and cicatrizing entropion. Why are these patients prone to develop microbial keratitis? Because of the exposure keratopathy, unhealthy and malposition of the adnexa, irritation by scales of the keratinized lid, the meibomian gland dysfunction, epitheliopathy and also vascularizing keratitis. The difficulties in these patients that we note is again applying lid speculum due to extreme lid eversion, risk of contamination while taking a sample, and evaporative dry eyes. And some patients also have limbal stem cell deficiency. Further, visual rehabilitation is extremely difficult in these patients because you cannot perform a graft because of the adnexal abnormalities. These patients required a combined approach in the form of ophthalmic management, dermatological management, systemic as well as psychological support. And most common prevention is useful in these patients. Hence, if lag ophthalmosis is absent, close follow-up and lubricant should be prescribed, and when present, eyelid management should be performed, and before visual rehabilitation, the adnexal pathology management is utmost important. So take home, ichthyosis requires an interdisciplinary approach. It affects the lashes, lids and the cornea, and these patients have exposure keratopathy, meibomian gland dysfunction and the abnormal adnexa, which lead to recurrent corneal epithelial defect along with secondary infection. Thank you.
Thank you, Dr. Maya. Excellent presentation and very difficult case because we know that all these patients who have systemic problems in form of ichthyosis or atopic dermatitis, they all create a lot of issues, and all the issues you have highlighted. I would like to ask one thing, the corneal sensation was absent or present in this patient?
It was very difficult to assess because of the total ectropion, but in the right eye it was absent.
And because when he presented he had difficulty in closure of the eyelids basically, and exposure was one risk factor.
Yes,
so
sir.
did we do anything for that?
No, our main focus was the healing of the ulcer. The oculoplastic surgeon did see it. We had started him on vitamin A, and they were later planning lid patch to put a patch graft for the lid.
Did they advise some surgical intervention for the lids or?
Now the patient is with them for follow-up. This was a very recent case, so the ulcer recently just healed.
Okay, thank you very much for excellent presentation. We move on to the next presentation, that is by Dr. Nidhi Kalra. She is there. Our next presentation is by Dr. Pushkar Rangare. Dr. Pushkar will present a rare case of tunnel infection following cataract surgery in an adult. Dr. Pushkar, please.
Good afternoon. I am Dr. Pushkar Rangari and I will be presenting a rare case of corneal tunnel infection following a cataract surgery in an adult. A corneal tunnel infection is a quite rare complication post phacoemulsification cataract surgery, and the most common organisms include fungal, which includes Candida and Aspergillus. Bacterial causes include Pseudomonas, Staphylococcus, Enterobacteriaceae and Nocaria. The major diagnostic challenge is because the cultures are often negative. It requires a multimodal therapy, and the visual outcome is variable depending on the extent of involvement. We had a 78-year-old male who didn't have any systemic illnesses. He had undergone a right eye phacoemulsification with IOL implantation under local anesthesia elsewhere. He had undergone a superior phacoemulsification for which a superior clear corneal incision was visible. An acrylic foldable posterior chamber IOL was put in, and thus there was uneventful cataract surgery. On post-op day 2, the patient had taken a bath. On post-op day 3, he had sudden diminution of pain with painful diminution of vision, along with starting of topical moxifloxacin at the same center. He presented to us on post-op day 4. His presenting visual acuity was hand movements close to face with PR accurate. His conjunctiva had severe congestion along with chemosis, and the lids had significant edema. The cornea showed ring-like infiltrate which was tracking from the main wound, and there was tunnel infection along the surgical incision. The IOL was present and it had a hazy view, but it appeared stable. There was no view of fundus. The picture shows severe chemosis and congestion, along with a ring-like infiltrate. A superior main port entry is seen, and a tracking ring-like infiltrate is seen along the wound. The B-scan ultrasonography was showing a stable posterior segment along with no retinal detachment, and there were vitreous echoes which was consistent with inflammatory debris. The corneal scrapings were negative for gram stain as well as culture. The culture sensitivity had reduced because of the prior topical antibiotics which he had received, and the therapeutic plan was adjusted based on the clinical response. Initially, we had given him intravitreal vancomycin and ceftazidime, along with topical therapy of fortified vancomycin, ceftazidime and natamycin, along with oral ciprofloxacin, and ring-like pattern was observed because of its topical and systemic fungal cover was given with voriconazole. On day 7, there was extensive corneal involvement, so we modified the treatment and started him on piperacillin, tazobactam plus polymyxin B, and a significant clinical improvement was noted. A surgical backup plan was of a therapeutic penetrating keratoplasty if there was medical failure. Why did we think of endophthalmitis risk is because there was water exposure along with a compromised wound integrity. This caused an environmental pathogen introduction which we had thought, along with a culture as well as gram stain negativity and antibiotic resistance which was suspected. Because through the EVS study we had established that vancomycin and ceftazidime is a gold standard for acute post-cataract endophthalmitis which we had suspected at the start. There was ring-like pattern recognition which prompted voriconazole addition. The clinical response to piperacillin plus tazobactam and polymyxin B indicated a gram-negative bacterial etiology, and sequential treatment modification demonstrated the adaptive management. The complete microbiological negativity, which included gram stain as well as culture, was the most diagnostic and the most challenging diagnostic scenario. And because there is extremely rare reported cases of ring-like tunnel infection, that's why the treatment starting was quite challenging. The clinical acumen actually in this case overcame the laboratory diagnostic failure. Empirical management achieved a good visual salvage and the patient improved up to 6/60 without any major surgery. This case has demonstrated an importance of systematic approach in a culture negative case. So what we conclude is that a post-operative patient education is quite critical for the prevention of these infections. A clinical acumen is essential for culture negative infections. Evidence-based empirical therapy can achieve excellent outcomes, and appropriate sterilization of equipments is of utmost importance. Thank you.
Thank you, Dr. Pushkar, for excellent presentation. You have added antifungal treatment on the basis of presence of ring infiltrate.
Yes, sir.
So what is the otherwise ring infiltrate is classical of which infection basically?
So the acanthamoeba shows a classical ring-like presentation along with severe headache along with it and severe pain, unbearable pain along with it.
That's true, but you are rightly that didn't want to take the risk and in absence of culture negativity it was good. Was the patient diabetic?
No sir, so he didn't have any known systemic illnesses. We also checked him for the systemic comorbidities in our center, but he didn't have any.
Anyway, very excellent result with empirical treatment, and that is a lesson to us that even if you are not getting any culture positivity or any help from the laboratory investigations, you should not get disheartened and use your clinical sense and treat these patients. Thank you.
Yes, thank you sir.
We move on to the next presentation, and that is by Dr. Suyash Saoji, and he is going to present his case on management of leukomatous corneal opacity with therapeutic keratoplasty. I request all the presenters to please stay back for the photograph because we have.
Good afternoon, everyone. I am presenting a case on management of leukomatous corneal opacity with penetrating keratoplasty. My patient is Bharat Sahu, age 53 years, male patient, resident of Damo, educated till 10th standard, occupation by farmer by occupation. Patient came with a chief complaint of diminution of vision in left eye since 2 years and whiteness in left eye since 2 years. As per patient, he was apparently alright 2 years back when he developed left eye diminution of vision, which was gradually in onset, progressive in nature. 1 month back, he came to the medical college with complaint of diminution of vision and whiteness over cornea in left eye. He has a history of viral keratitis in left eye 2 years back, for which he took some treatment in private hospital, and he had taken the treatment of tablet acyclovir 400 mg OD for 3 months and ointment ganciclovir 0.15% in BD. Patient don't have any chronic illness. Family history is not significant. There is no addiction history. General examination was normal. All the systems are within normal limit. On ocular examination, right eye is WNL and left eye has a vision of counting finger 3 feet. In cornea, size and shape is normal. Leukomatous corneal opacity of size approximately 6 into 7 mm present centrally covering the pupil. Transparency is hazy. Vascularization, supervision and deep vascularization are present, and corneal sensation are decreased. Rest is WNL. On fundus examination, right eye is within normal limit. Left eye is hazy due to corneal opacity and cataractus. This is the pre-op examination images. Other investigation like CBC and LFT, RFT are within normal limit. We have advised treatment of left eye optical penetrating keratoplasty. On post-op ocular examination, on post-op day 1, vision was improved to 3/60. On post-op day 1, conjunctival and circumcorneal concision were present. Corneal graft of size 7 mm present in center with 16 nylon 10-0 radial. Interrupted suture present between graft host junction on equidistance from each other. Descendant folds were present. No infiltration KPs were seen. Corneal sensation are decreased. Pupil is circular in shape and heterogeneous mid-dilated, sluggish reacting to light. Lens is cataractus. On day 7, vision improved to 5/60. Base corrected visual acuity was 6/36. Circumcorneal congestion was relieved, and there is some mild conjunctival congestion. Corneal graft is at place and healthy and intact. Descendant femorants were present. Lens is cutted and pupil shape is normal and sluggish reacting to light. On day 13, vision was improved to 6/24 with base corrected visual acuity 6/18. Graft is at place and intact, and pupil has now come to normal shape and reacting to direct and consensual light reflex. Lens is cataractus. This is the corneal diagram. Left eye AIOCMTC4 was taken on day 13, which shows normal within normal limit. Pachymetry was also taken. On this right eye shows central corneal thickness of 464 micrometer and left eye 527 micrometer, which is within normal limit. Left eye OCT was macular OCT was done, which is also within normal limit. Post-op treatment was advised this. On local moxifloxacin and dexamethasone 1 hourly was given initially. Homatropin BD was started and CMC 6 times per day was given. On discharge, treatment advice was moxifloxacin was given 8 times per day, CMC for 6 times per day, and ointment Lacrygel BD. A patient came on follow-up for on 20th day. Visual acuity was improved to 6/24 with best corrected visual acuity 6/18. Further treatment was advised suture removal after 6 months to 1 year. Thank you.
Thank you, Dr. Suyash, for excellent presentation. I have a few questions for
Yes,
you.
sir.
You are saying leukomatous corneal opacity, and then you are saying management with
Sir, that was,
therapeutic.
Sir, that was wrong. After I have sent email, but that was not changed title. I have taken other case, but
Okay.
that patient has
Okay.
lost for follow-up.
Okay, okay. So it's optical penetrating
Yes, sir.
keratoplasty, nothing to do with therapeutic. Other thing is that patient had significant cataract.
Yes,
So
sir.
why we left cataract at the time of corneal transplant surgery?
Sir, that depends on the sir. Consultant has not done cataract surgery.
Anyway, the most if your patient is above 50 years,
Yes, sir.
you should always be prepared for performing cataract surgery along
Yes,
with
sir.
your corneal transplant surgery, and do biometry, all other tests, whichever test you want to do. Prepare yourself about that, and take your lens power and lenses
Yes.
along with that. And because the reason is that if you don't do cataract surgery at that time, later on when you are doing cataract surgery, you are going to damage more cells.
Yes, sir.
So that is better to do at that same time. Anyway, thank you so much.
Yes, sir. Thank you, sir. Thank you, sir.
We move on to the next presentation, and that is by Dr. Himanshu. He is going to tell us about managing posterior keratoconus with IOC assisted DAL, overcoming surgical challenges.
Hello. Good afternoon, everyone. So I am presenting a case of
Slides.
post
Slides.
on. A minute. It's on. Good afternoon, everyone. Myself, Dr. Manshu Khandelwal. So I am presenting about a case of posterior keratoconus in which IOCT assisted DELC was done. So coming to our case, a 65-year-old gentleman presented with complaint of diminution of vision in right eye since childhood in our OPD. He has developed gradual painless diminution of vision in right eye since last 10 years, which was not associated with any pain, itching, foreign body sensation, redness, rubbing of eyes, anything. And we made the diagnosis was made with right eye posterior keratoconus in which central corneal thickness was 201 micron, and the patient was registered for right eye DELC. So what is posterior keratoconus? It is a rare, non-progressive and non-inflammatory ectatic disorder of the cornea in which there is an increased curvature of posterior corneal surface. Butler classified it into two subtypes. One is generalis and other one is circumscriptus, which is localized form. So coming to our examination, the visual acuity in the right eye, it was 1/60 and it is not improving further. In the left eye, it was 6/9 with improving to 6/6. So on examination, there was a paracentral 2.2/3 mm of corneal thinning was there along with the nebulomacular opacity. Rest eye was within normal limit. So coming to the investigation, the ASOCT shows the posterior depression with thinning of the central cornea, and on pentagram maps we can see the Kmax of around 58 micron and elevation and the increase in the posterior elevation, while left eye is almost within normal limit. Coming to the video, so white to white was measured and the central marking was done on the microscope. And we can also see the intra-op OCT which is running throughout the case. So central cornea is marked. After that, central 8 mm trephination was marked onto the cornea. Now the manual dissection was done with the also with taking the help from the intraoperative OCT. And then the manual dissection was completed. And since it's a keratoconus, so we use the almost similar size, just we take the oversize of 0.25 mm in the graft, and the graft was sutured with the host bed with the help of 10-0 monofilament nylon. And so all the interrupted 10-0 monofilament 10-0 monofilament nylon was put, and at the end we can see the descemet membrane and endothelium well attached to the donor cornea, and the BCL in the end BCL was put, and the on keratoscope we saw the circle is circular. Thank you.
Thank you. Thank you, Dr. Himanshu, for excellent presentation. These cases are really difficult, and I think IOCT has really helped us. The good thing is that you do the peripheral dissection, and because the central part is quite thin, yes, so you can just peel away, yes, sir, and you get the desired level of thickness.
Sir,
okay. Thank you so much.
Thank you.
We move on to the next presentation, that is by Dr. Arushi Chaudhary, manual intacs in keratoconus.
Good afternoon everyone, I am Dr. Arushi and today I will be presenting a case on manual intacs in keratoconus. So a 19-year-old female presented to OPD of the hospital Bhiwani with the chief complaints of blurring of vision and frequent change of glasses since 3 years. There was no other significant history except for chronic ocular allergy which was associated with frequent eye rubbing since childhood only. The ocular examination, the unaided visual acuity was 6/12 in the right eye and 6/36 in the left eye. On retinoscopy, scissoring reflex was seen in both the eyes, and the anterior segment was within the normal limits, and best corrected visual acuity was 6/6 in the right eye and 6/9 parts in the left eye. After that, pentagram was done for both the eyes, which came to the conclusion that the patient is suffering from bilateral keratoconus, more pronounced in the left eye than the right eye. And the procedure planned was left eye manual intacs implantation and right eye C3R. So the surgical nomogram was prepared, and according to the patient parameters, 0.45 mm intact SK segment in the inferior section was planned. So here we go with the procedure. This is centration is done, central marking is done, and after that we do the segment placement marking. The diamond knife is set at the 70% of the corneal thickness, and incision is given vertically. After that the pocket creation is done, and dissection is carried out with help of the spreader. Tunnel is created once in clockwise direction, then in anti-clockwise direction, and the intact delivery is done with the help of McPherson forceps, and Sinski hook helps in the subsequent placement of the ring segment. So what we see that pre-operatively the left eye vision was 6/36, which was improving to 6/9 parts. Status post day 1, the left eye vision was 6/12 parts, which was correcting to 6/6 parts. And status post 1 week, the left eye vision was 6/12, which was improving to 6/6 parts again. Status post intact 1 month, the intact ring was in place, the vision was stable, and no segment migration or exclusion was seen. Unaided visual acuity of the left eye was 6/12, and of right eye was 6/9 parts. And the glasses prescribed were -1 cylinder at 115 degrees in the right eye, and in left eye it was spherical -2.50, with the BCVA of 6/6 in the right eye and 6/6 parts in the left eye. So here we can see that the post-op period of the patient was uneventful in status post 1 month follow-up as well. So this brings us to conclusion that manual intakes are a viable option for the young patients who have keratoconus, who have central clear corneas, and who are intolerant to contact lenses. It's just that the patient selection criteria is important, and what intakes does is it helps flattening the cornea in the area of protrusion and reduce the astigmatism by the arc shortening effect. And there are some contraindications of the procedure as well. That is, if there is central corneal scarring, herpetic keratitis, and if there are some connective tissue disorders along with the pregnancy. And also if patient is on drugs like sumatriptan, so for migraine, so also in those cases the manual intakes is contraindicated. Also it delays the need of penetrating keratoplasty, and the added benefit is reversibility. Thank you.
Thank you, Dr. Arushi, for excellent presentation and excellent outcome of this case with the manual intact. What was the age of the patient?
So 19 years.
So did we combine collagen cross-linking with the intacts or?
No sir, for right eye it was planned. It was advised to the patient that she combines C3R with intacts in the left eye as well, but she was not really willing.
Okay, so it's basically the two things are different. Intacts will take care of the astigmatism part and will decrease the irregular astigmatism, but progression of the disease will be arrested only by the collagen cross-linking. So that part has to be kept in mind. Anyway, thank you so much. We move on to the next presentation by Dr. Bhumi Chandrana. She is there? No. She is also not. So with this we come to the end of this session, and I request all the presenters to come forward for photograph if there are any.